topic is antenatal magnesium. Does it prevent cerebral palsy? And for this, I am going to invite Dr. Nishant Banait. He is MD CESR Neonatology UK, Fellow Neonatal Medicine RCPCH UK. He is a consultant neonatologist from Cloudin Hospitals, Pune, and he has served as consultant neonatologist in prestigious Royal Victoria Infirmary, Newcastle, UK. So I call upon Dr. Nishant Banait to present his talk.
Lights off करो. Good morning, everyone. Thank you for those kind words. I'll start with my topic, which is antenatal magnesium use for neuroprotection in preterm babies. Does it really prevent cerebral palsy? I would discuss this under various objectives of the talk. Are what is the burden actually of cerebral palsy, and what are the mechanisms which cause this dreadful disease, and what is the role of magnesium, why we are looking at this evidence, and the evidence available over the last 20 years, and at last shall we be using magnesium at all. So cerebral palsy, as you know, is world over the incidence is reported as 2 to 4 per 1,000 children, and most common is the spastic cerebral palsy, making up to 70 to 80% of all cerebral palsy cases, and this produces a very high socioeconomic burden on the society. Unfortunately, the data from India is not available because the census of India counts all cerebral palsy cases under locomotor disabilities, which will include cases of short stature also. So you don't know how much of that is just cerebral palsy. So what happens, what causes this cerebral palsy is not really completely understood, but from the animal studies as well as the various clinical trials, it's been noted that the main events which lead to this are the hypoxia and reperfusion injuries, then infection and inflammation processes, then excitotoxic cascades like glutamate and pro-inflammatory cytokines and oxygen free radicals all have been implicated as the cause. What is the mechanism? So this is a busy slide, but what it means is basically prematurity, there is hypoxia and ischemia, plus some role of infection leading to increased extracellular glutamate, which is a excitotoxic kind of neurotransmitter. And all of this leads to basically damage to the growing neurons, and which causes white matter injury as well as gray matter injury, leading to cerebral palsy and cognitive defects also. So preterm labor leading from inflammation, free radicals, then excitotoxicity and white matter damage, plus the repair itself can be problematic. So in the preterm brain is mostly the pre-oligodendrocytes which are affected by the hypoxia and ischemia, and with the process of this injury as well as the re-healing process, it leads to reduced connectivity in the neurons, which leads to impaired neuronal networks, leading to various motor defects. So what has been the focus of research in protecting the preterm brain? So there have been a lot of research going on in this slide, but the most right from antibiotics to steroids to features like erythropoietin, enol nitric oxide. But what has been there for last 20 years is the magnesium. So how does magnesium actually prevent this? So the preterm brain, it basically it is a vasoactivation. Magnesium, it sort of stabilizes the blood circulation, cerebral blood circulation. It also blocks the NMDA receptors for glutamate. That's why blocking the excitotoxic effect, and it also reduces calcium influx and the inflammatory cytokines. So where does this come from? It begins in 1985 when there was some observational data which suggested that the magnesium being used mainly for tocolysis at that point. But what they found by observational data was it probably reduced IVH, intraventricular hemorrhages. Then they came up with this cohort and case control studies which showed that there is less of cerebral palsy after use of magnesium in antenatal use of magnesium, which was sort of coincidental findings. So in the last 2 decades, there were 5 RCTs and randomized control trials using magnesium mainly as a neuroprotective agent for preterms rather than as a tocolytic or for eclampsia, prevention of eclampsia. So these are very good quality studies, and there was no low risk of bias, mostly double-blinded studies, and most had primary outcome as neuroprotection rather than tocolysis or eclampsia. So after these 5 RCTs, the first Cochrane review was published in 2007. It only included 4 RCTs because the 5th RCT was still in process. So the first study was the magnet study, which was conducted in USA. It was a single center study, included 149 participants only, and the dose they used was 4 grams of bolus magnesium sulfate, followed by maintenance of 2 to 3 grams per hour. Then the second was in Australia, 16 centers, 1062 participants. The dose was slightly different. Then MACP study included 1500, more than 1500 participants. Again, the dose was similar to the previous one. And the last one is the pre-MAC study, which is was conducted in France. So all these studies were during the duration of 1995 to 2004. And they only used for 4 grams bolus, but no follow-up maintenance doses in the France study. So the Cochrane review concluded that only a possible beneficial effect of magnesium in preventing gross motor dysfunction, and but it did not reach statistical significance. But then came the mother of all these studies, which was the BEAM study, beneficial effect of antenatal magnesium, published in New England Journal at that time. So this was the largest multi-central placebo-controlled double-blind study, and mainly looking at prevention of CP. So it included 20 centers and more than 2,200 women were included. The dose they used was slightly higher, 6 gram loading dose, followed by 2 grams per hour of infusion. And the primary outcome was the composite of infant death by 1 year or moderate to severe CP at or beyond 2 years. So I think here they went wrong with the including the two together, because if somebody dies, he cannot have CP, so you cannot have a combined outcome for both of them. So the results they came out was the primary outcome being combined, that there was no significant difference between magnesium or no magnesium. But when the results were broken down into what is the difference between mortality and separately looked at cerebral palsy, the cerebral palsy occurred significantly less frequently in magnesium sulfate group. So after this study, the Cochrane was updated, including this study, because this being the largest study. And you can see the forest chart, it has changed to in favor of the magnesium sulfate for prevention of moderate to severe cerebral palsy. So after this, the cerebral palsy risk, relative risk, after this Cochrane review came down to 0.68. So it was quite a significant improvement in the the role of magnesium sulfate in prevention of cerebral palsy, and the gross motor dysfunction risk ratio came down to 0.61, and the number needed to treat was about 63. So 63 mums have to be treated with magnesium sulfate to prevent CP in one baby. So after this, there are 3 milestone studies again came in, all meta-analysis at different places, including the same 5 RCTs, and all came up with the same results, showing that the magnesium, okay, yeah, showed that the basically came out with the same results, that magnesium is really helpful in preventing cerebral palsy. And they quoted that the moderate to severe CP can be reduced as much as 40 to 45% without increasing the rate of death. So that is quite a significant result from these RCTs. Based on these RCTs, the various organizations came up with their guidelines. So the American Congress for Obstetrics and Gynecology came up with a consensus statement in 2010, but they included only the largest 3 studies, and based on that they told that the relative risk is still sort of hovering around 1. So they didn't really gave a clear guideline, but told that magnesium has definitely got a role in preventing the preterm brain, and they left it to the physicians to use magnesium sulfate and create a guideline for their own setups and use it for prevention of cerebral palsy. The Australian and the New Zealand guidelines were very clear. They are using it universally, and this basically is the guideline which is used all over Australia, and they give magnesium sulfate to moms who have the indications being the delivery is anticipated before 30 weeks, whether it's a planned or definitely expected within 24 hours, regardless of whether what is the cause of preterm birth, what is the plurality, what is the parity, or it's a planned or not. And the regimen they are using is loading dose, which is a 4 grams loading dose over 20 to 30 minutes, followed by 1 gram per hour infusion, which is a maintenance dose. And this has to be continued regimen until the birth, or at least for 24 hours, whichever comes first. If the delivery doesn't occur, then you can actually repeat the dose. That's what they recommend. But if the delivery is still imminent, you can continue to give the maintenance dose. But you should not delay an urgent delivery for getting in the magnesium. So this was Australian. Then came the UK guidelines. They endorsed the Australian recommendations, and they suggest that the various trust hospitals should have their own guidelines. But being in UK, I know that it's partly, it's not really used in UK also. The Canadian guidelines also similar, but they instead of 30 weeks gestation, they are using 32 weeks as the cutoff for giving magnesium. So all of them are recommending it, but some of them are practicing it. Then came this study from China, which not included the RCTs, but also included some cohort studies. Again, the result was pretty much same. It showed that the moderate to severe cerebral palsy can be reduced by, the odds ratio was 0.61. So very significant result again. So if you see, the last RCT was done is in 2004, and there have been actually no studies after that. It's only been meta-analysis. So the Denmark study had a very interesting point of view that say that there is, when you do sequential meta-analysis, you can always get a random error in the published meta-analysis. And with some tricky statistical methods, they came up with a number 1240. If this around 1200 participants are again undergo a randomized control trial, then those results can be actually be significant. So hence 2 new multi-central trials are coming up, and they are actually in process, mainly in Scandinavia and Australia, in which they are using preterm babies who are maybe born at 24 to 32 weeks, and they are randomized to receive magnesium sulfate or placebo therapy. So we'll soon have these results. Then the question always comes in the obstetrician's mind is the problems with magnesium sulfate. Yes, there are side effects, but these are not serious or not. There are no adverse effects at all. So if you combine all the data from all these studies, there is hardly any death or cardiac or respiratory arrest attributed to the magnesium use. But yes, there are symptoms like flushing. There are problems at the injection sites, and sometimes sweating, but all of this can be managed. So to summarize, it all started in the US in 1985, when they came up with the first RCT. Then the Australia and New Zealand came up with a guideline. They were very strongly recommending use of magnesium. Then the Canadians also, the British also followed them, but they are not really practicing, and the Canadians have a guideline again to use magnesium, and it's been routinely used in Canada. So the Chinese came up with another RCT, another meta-analysis, and showed that yes, we should be using it. But because the Europeans were feeling left out, they have recommended one more RCT. So this will go on, and till what end we are going to wait to use magnesium sulfate, we don't know. What I wanted to focus is that we are always getting delayed in adaptation of evidence-based medicine. We all say we will follow evidence-based medicine, but we are, lagging behind by a decade or two. If you look at the antenatal steroids, the first trial, you'll hear that in the subsequent lecture, that the first RCT was published in somewhere 1975, but the actual practice of antenatal steroids routinely came into practice only in 1990s. So there was a delay of, say, 20 years. Same with surfactant therapy, and we are still struggling with therapeutic hypothermia. It's a standard therapy right now in many of the centers, many of the countries, but we are still not using it. So shall we do that with magnesium also? I don't think we shall, because I can understand the cost problems with surfactant and hypothermia. Being a developing country, we are having these problems in terms of the cost of the treatment. But magnesium is really, really cheap treatment. And if we can prevent one cerebral palsy, that will be a great contribution to the society. Okay, thank you.